welcome to the last bariatric information webinar of the year. We'll just give it a few minutes while everyone joins onto the session. My name's Abby and I'm from ABL Health, and tonight we've got Jodie, bariatric nurse from Salford Royal, and we've got Lucy, a triage nurse from More Life with us as well. This evening Jodie is delivering the session, which will consist of a big quiz to round up all the sessions of the year. And the webinar tonight is recorded and uploaded onto our YouTube channel, which you can find by searching for ABL Health on YouTube. And I'll also post the link into the chat box as well. The session is recorded, like I said, but as it's a webinar, we can't hear or see you, so don't worry about that. I'll also post the link to the private Facebook group in the chat as well, which you can join to support one another and ask questions and keep up to date with each other's journeys. We do monitor the group, we just ask you for kindness and support for one another. And I'll also post the link for the feedback survey as well, which we'd be grateful if you could complete to let us know how you're finding the sessions. Following hearing from Jodie, there will be time for question and answers at the end of the session. So you can use the Q&A box at the bottom of your screen and ask any questions that you've got. And Jodie will filter through, see if there's any that would be useful to answer this evening based on the topic she's discussed. If you have questions relating to the weight management programme you're on, please direct these to the weight management programme provider, as one answer doesn't fit all. So we won't be able to answer anything directly related to different providers of your weight management services. Jodie, I'll hand it over to you.
Hi, brilliant. Hi, everyone. So thanks for that, Abby. So if this is your first time here, welcome. This is our support group way of giving you information every month, except for the month of January. So when we do these sessions, you'll ideally meet all different people from maybe your weight management service, and definitely from our team at Salford, so our surgeons and our medics, our physicians, our dietitians, our psychologists, everyone that makes up our team at Salford where we do the surgeries. And so this is the end of year quiz, so hopefully you'll get some information. It's a little bit interactive. If you go into the webinar chat, you should be able to see like a little sort of smiley face icon, and if you press on that, it will show you all the different emojis that you can stick out there. So I'm going to have a screen that will have a question on it, and you just need to decide to yourself, is this true or is this false? So I think we could probably choose a smiley face to kind of indicate whether you think it's true or false. So I think if it's true, you could perhaps go with the chat with the sunglasses on, and if you think it's false, maybe an upside down smiley face. I'm happy to go with anything that you think is happy and true, so it could be a smiley face for true or a sad face for false, just so we can get a little indication of what you guys are thinking out there. What I did before the session is I did ask the wider MDT if they could perhaps do a few quotes for me. And I'm not saying that they're all the answers are false, but they were trying to do trick questions. So they were trying to catch you guys out. So yes, I hope you find tonight enjoyable. I hope you find it informative. But don't worry, if you've come here tonight seeking out certain information, as Abby said, there are recordings of the different professionals that have done talks. You might find them there. And then, of course, we've got next year where we'll have our sessions again. In February, we're going to have Dr. Raj Majulia, who's a bariatric physician. He'll be doing a talk, and then we'll have a patient experience, the one after that, which is always really popular and positive. So let's get to the quiz. Brilliant. So we're sharing the screen. We'll get that up. So the first question, please, Abby. Right, so further weight loss should be achieved for the day of bariatric surgery. So what do you think? Smiley face for true, or sunglasses, or sad face, or upside down face for false? I'll just give you guys a chance to find that function, because it took me a while when I was first doing it. So you go into the chat, and then you can just see where it says 2 and it'll say host panelist. There's like a little smiley face, emoji face thing there. So I don't know, is that working? Are people pressing on it?
I think it might not be working, Jodie, tonight.
Is it not? Oh no,
No.
that's too frustrating. Okay, all right, we could do it another way. We could just say in the chat, let's see, what else can we do to make, just to
We
get a
could
little
raise
bit.
our hand if we think it's true, maybe.
Yeah, because there are 287 people on this chat tonight. That will work. Yeah, so if, well, hang on a second, will it though? I'm just thinking it'll only come on the screen. No, hang on a second. Let's go in the Q&A, because we normally do get love hearts and claps and things for it, so I'm just trying to figure out how that happens. Okay. Yeah, maybe the chat's not enabled. Okay then, no problem. Let's just get to the answers and hopefully it may start working during the session. Brilliant. Okay then, so next slide, please. True. So of course, weight is not an easy thing to lose, otherwise you wouldn't all be here this evening. And very often weight fluctuates going up and down. So even from the time you meet us, you might find that you put a little bit of weight back on and it comes back down and up on. The reason it's true that you're going to lose weight before bariatric surgery is because of the liver reducing diet. So our liver is a big whopping rugby ball that sits in our thoracic region near where we want to do our surgery, and there's also other bits of organs and the lower part of our lungs and other things around that region as well. So what we want to do is target the glycogen, the liquidy part of the liver, and with the specialized food-based diet, I emphasize this food-based diet because we don't want people on liquid diets for the liver reduction and then a liquid diet after bariatric surgery, because that's an awful long time to not chew anything. So we have a food-based diet for your liver reduction. All that information is given to you when you come and meet our team, and it will target that fluid, so everybody will lose weight with the liver reduction diet. Okay, next slide. I will have 8 laparoscopic incisions. So laparoscopic is a term used for keyhole, which you may be more familiar with. So this is where the surgeon's going to make some incisions across your tummy, pop in their apparatus, their laparoscopes, to then be able to carry out your surgery. So how many incisions do you think you might have across your stomach? Okay.
So raise your hand if it's true. I've got 15 people with their hands up so far.
Oh, so the hand thing does work. Okay.
Yeah, I can
Brilliant.
see it.
Okay, so we can use hands. Good, good. That's great. All right then, so I'll give you a few minutes. So do you think you have 8 wounds across your tummy? What do you think? True or false?
We've stabled out at around 74
Okay,
people.
brilliant. Right, next slide, please. It's false. Whilst many bariatric surgeries are carried out with a predictable number of keyhole incisions, usually 5, so you would expect to have 5, you may have an extra incisions for other ports to be placed. This allows for improved access whilst the team performs the procedure. This should have no bearing on your postoperative discomfort, overall recovery, or resultant weight loss. And that comes from Mr. John Saunders, who's one of our consultant surgeons. So yeah, in all my time, the vast majority of you are going to have 5 laparoscopic wounds across your tummy. They're the wounds on the outside. When we do your procedure, you'll have a staple line or 2 staple lines, depending on which procedure, inside. So there's wounds inside and then there's some wounds outside. In all my years of doing this, the most wounds I've ever seen is 7. And it's perhaps a little bit more frequent that you may have 6, and that's simply because everybody's anatomy is slightly different. If they can't see safely where they want to be, they'll make another incision so they can. Okay. Next slide. We offer 3 types of surgery. So raise your hand if you think that's true. Could do with like a little countdown clock or something.
Yeah. We're evening out at around 100 people with their hands up.
Okay, so next slide. It is true. So when services use some services, and also included, used to offer things like gastric bands, we find that they don't really achieve the weight loss that's needed, nor are there the post-operative services available for tweaking and adjusting those bands in the way that would be desirable to get the ultimate weight loss. They're a good weight loss tool for somebody who really struggles with portion control, but other than that, they won't really get rid of hunger or cravings, or very often we see people that have lived with over tight bands that cause all kinds of problems to the anatomy. So gastric bands are not something that we routinely we do anymore. The 3 surgeries we do, and we class these surgeries as a major surgery because they're an abdominal surgery. They're classed on par as safe as having, for example, a gallbladder removal. So the 3 types we offer are the laparoscopic Roux-en-Y bypass, the laparoscopic sleeve gastrectomy, and the laparoscopic single anastomosis bypass. Very rarely do the surgeons ever need to make that incision bigger, which would then mean it wouldn't be a keyhole procedure, it would be an open procedure. But for the vast majority, you'll always have a keyhole or laparoscopic surgery, and it's 2 types of bypass that we perform, and the sleeve gastrectomy. And that's from Professor Kershid Akhtar, our consultant bariatric surgeon. If you're wondering, what are all these? I need to know more about them. That's fine. Our surgeons will come and be doing talks throughout the year, or you can find talks that they've already done recorded. Single anastomosis gastric bypass has more than one name. Okay, so when we're thinking about a bypass, you think of your surgeons as plumbers rerouting the anatomy you have inside. So they're going to leave you with an egg-shaped stomach that joins bowel further down. So the rest of the stomach and the bowel you no longer use is still there, has a blood supply, still does a job with bile juices and gastric acids and so on. But where food goes down is through your new egg-shaped form stomach and bowel that's pulled. So you get this sort of malabsorptive effect and then the restrictive effect. The way we do those surgeries is either a Roux-en-Y gastric bypass, which is to do with where we make the join for your bowel further down, or the single anastomosis gastric bypass. So anastomosis, just for your research purposes, is a fancy join which involves bowel. So that's what the term anastomosis is literally a surgical join inside. So for a bypass, when you're researching them, it's important that you understand there's 2 types we offer. There's only 2 types that are done anywhere at the moment. So let's see, is there more than one term for a single anastomosis gastric bypass?
We've evened out around 80 people with their hands up.
Okay, brilliant. It's true. There is, and it really annoys me because when you're doing your research, you can suddenly think, oh, I'm looking at gastric bypass, and if you just type gastric bypass into a Google engine, more than likely it's going to talk about the Roux-en-Y gastric bypass because that's the one that has been around the longest, has the most evidence base and hits and so on when you go out there into the internet and so on. So be aware. For the single anastomosis gastric bypass, it is the exact same surgery, but it's also termed as the mini bypass, which is the one I hate the most because there's nothing mini about it. It's still exactly the same surgery, so there's nothing mini about the bypass. The one anastomosis bypass and the Omega loop bypass, and it's just to do with how they make that surgical side and surgical join. So with the Roux-en-Y bypass, there are 2 surgical joins inside. With the single anastomosis, there's 1 surgical joint inside, and when you meet the surgeons, there's reasons why they may sway towards one bypass to the other bypass, and obviously your patient choice is really important as well. So that was from Mr. Chris Grocock, another of our consultant surgeons. You should stay in bed for at least 24 hours after bariatric surgery. What do you think? True or false? So true with a hand, please. So what do you
Got
think?
around 60 people.
Okay, so brilliant, because there's 307 or 308 people joined us tonight. So let's look at the next slide. No, it's false. You getting moving early is associated with less pain, a feeling of well-being, less complications from surgery such as chest infection or deep vein thrombosis. The earlier you get up and walk around, the faster you can go home and the faster overall your recovery will be. And that comes from Dr. Dominic O'Connor, who's our consultant anaesthetist. And essentially, this is the same pretty much for any surgery that people have. But I particularly think it's important when you've had a bariatric surgery, because we've messed around with your bowel and you've got swelling where your stomach is and you're taking sips of water. At first, you're going to be really burpy and quite bilious, but it's important that you do get hydrated. And sometimes when you have that kind of burpy, bilious feeling, you feel a bit nauseous. So the quickest way to wake your bowel up and say, no, we want things to go down the right way again, and essentially for you to pass wind rather than burping, but the other end, which I know people don't always like to talk about on a Wednesday evening, but that's a really good sign that once you pass in wind, that things are going back to normal. So everything's going to get a lot easier. That heavy feeling, that burpy feeling, all the trying to get drinks down initially, things will get easier. So gut motility is really important. So whatever your normal mobility is, getting back to that as soon as possible is really important, for all the reasons there as well. Okay, next slide. Okay, I should eat 20 pence piece mouth sizes of food per mouthful post bariatric surgery. Okay, so that means that when you're attempting a meal after you've had bariatric surgery, you should never be putting a portion of food bigger than a 20 pence piece into your mouth. What do you think? Is that true or false? So it's a hand up if you think that's true.
So we're nearly at half.
Okay.
Nearly half of the people have said true.
Brilliant. And it is after bariatric surgery. Sorry, next slide. After bariatric surgery, it's really, really important that you stick to this, because you're literally weaning that new stomach like you would wean a newborn baby. So we'd start with just a liquid diet. And then once you move through onto puree to soft to solid foods, it gets easier to apply those rules of 20, because obviously we were asking you to choose something. So you are recommended to follow the 20-20-20 rules. This is a 20 pence piece size mouthful. You chew it 20 times. You put your knife and fork down, or it may just be a tip of a teaspoon with your puree and soups and so. For 20 seconds between mouthfuls. And then you finish your meal either when you feel full or you get to 20 minutes. So whichever comes first. If you get that full feeling, you stop. Or if it's 20 minutes that you've been spending on that meal, then you stop. And this will ensure that your body can digest that food down. Because remember that the big sack that was your stomach, which is essentially just a carrier bag that stretches out when we're eating a meal, and everything churns around in there, you don't really get, you don't have that anymore. So your mouth is essentially that. You need to chew that bolus down really, really well, and then swallow, and then wait time to allow that to go into the egg-shaped stomach and start to filter out so you can take the next mouthful. So even with fluids, people can find if they're having it too quick, it's overwhelming the little egg-shaped stomach and things try and come back up. There's a popular thing with our post-op group where they describe something called the foamies, and that's where food has gone down too quick, or they've had a mouthful of food, they thought, oh, this will be all right, this nice mashed potato, and maybe they've just had it a bit too quickly, and it's sitting there, and then because the pouch is too full, lots of gastric saliva juices and so on are around that, and they're trying to digest it in that little egg, and it's not designed for that anymore. We want things to gently be going through. So what will happen is, because all of those digestive enzymes and juices are there, you'll get like kind of a thick, slimy, frothy content coming up into your mouth, and sometimes you may even regurgitate that undigested food. It doesn't happen that often, but it's just something to be aware of. I had a clinic this afternoon, and a lady said she was watching, which I can't remember what it was. Oh, I'm a Celebrity, Get Me Out of There, and she had a small pot of cottage cheese, but she was only planning to have half of it, and because she was watching it and she was kind of like not thinking about it, she just had it that bit too quickly and just sat there until unfortunately a little bit came back up, and then she was okay and down it went, but it was hours until that kind of filter effect could happen. So it sounds a bit nasty. Obviously you recover from it and you learn very quickly to always stick to the rules of 20, and that comes from our lovely Abby. Thank you, Abby. Next slide. Right, there are two types of dumping syndrome. So if you've just joined or you're just starting to research bariatric surgery, dumping syndrome is essentially when you've eaten something that's too sweet, too greasy, or too starchy. And now because things go quickly into the small bowel and the small bowel is not used to having things like that straight away into its system, they will try and evacuate it. It'll draw fluid from your circulating volume to flush the item out. So it probably will end in an episode of diarrhea, and you might feel quite odd. You might get palpitations, sweats, you might feel quite ill, you might feel like you just need to take to your bed for a few hours, and then your body resets and you're absolutely fine. But it's just something to avoid, which is why starchy, greasy, and definitely sugary foods need to be avoided. And it's much more pronounced in the bypass than the sleeve, but it's still common in the sleeve as well. So the question is, there are 2 types of dumping syndrome. Is that true or false? What have you got, Abby?
We've got about a third of participants raising their hand.
Okay, brilliant. So well done to that third, because indeed it is true. Okay, so our very clever Professor Akhil Syed, he's a consultant endocrinologist, which is he wears many hats. So he's a bariatric physician, an endocrinologist, a diabetologist, and you'll probably meet him when you come to our clinic. So what he's letting us know is there is an early stage and a late stage to dumping syndrome, and this is particularly true of any sugary foods. So early dumping symptoms occur at least 10 to 60 minutes after food caused by a dumping of solid food into the intestine with rapid shift of fluids into the small bowel. You could feel faint, palpitations, fatigue, and the desire to lay down. The late stage symptoms can occur 1 to 3 hours after eating the food because of the fluctuations in your blood glucose levels. You might be sweaty, you might feel shaky, and you may feel a bit experience decreased alertness. The key to managing both forms of dumping syndrome is good post-surgery dietary habits. So again, it's just to make you aware, because often I'll say, oh, can you think of anything you ate or drank before that episode? And normally it might be, oh, well, actually I had some fresh orange juice, and that could be okay. And maybe 125 mils of orange juice would be all right, but more than that could be too sugary from all the fructose. And the way your body deals with when we have sugary things is it pumps out insulin. So if it's dealing with a small amount of something that's gone into your small intestine, it's squirting out a load of insulin, you can then get this late dumping where your blood sugars have gone high, and then they've been combated and they artificially go low, and then they settle out again. So this is why you can get this late dumping. So that's more associated to sugar and the way it's affecting your blood glucose. Okay, next slide. Bariatric surgery cures diabetes. What do you think? So if you think it's true, raise your hand.
It's many. Just 60 out of 300 have raised
Very
their
good.
hand.
I thought this would catch more people out, because I thought this was one of those sneaky trick questions. The next slide. It's false. However, we love it for diabetes. Type 2 diabetes, it's just amazing, especially the bypass surgeries. So in some cases, diabetes can go into what we call a full remission. So we're not allowed to say the word cure. We say remission, which means your HbA1c, so the blood glucose level that shows us that you're diabetic, will go below a level of 42 quite regularly, quite quickly after bariatric surgery. Which means you no longer require any medications. You will always need to continue attending clinics for management for eye and feet checkups. So because you've had diabetes in the past, depending how long you had it, it could have caused some damage for long-term health. And therefore that eye and foot check is important. And then you attend that annually. Okay, next slide. Oh, that came from Dr. Lucinda Summers, who's one of our consultant physicians who you would more likely see in your annual reviews after bariatric surgery. Social media is an excellent source of information. So raise your hand if you think that's true.
We've got around 80 people with their hand
Yeah,
up.
I think we're getting wiser, aren't we? I mean, we're so lucky, and our kids use it for their homework, and we could be sat there thinking, oh, I can't remember what the side effect of that drug was, and we can have a look up, and we know where to look. So it's true and false. So it can be really useful. So if we're telling you about a bypass surgery, and we say, look, go on to Google Scholar, you can find papers if you want to look at it that way. But really, it's a double-edged sword, and I think for people that have had bariatric surgery, there's loads of groups now that are popping up, Facebook groups. That I think ABL, you have a Facebook group, and all kinds of things on YouTube, people you can follow on their weight loss journeys. And I think all these things are really good for celebrating and raising awareness. But then also they can really, they can be associated with false information, and they can really increase anxiety, because we work when we do our follow-up, it's a sort of strategic times after surgery, so we can tell you about your excess weight loss percentage. Now, your excess weight loss is the amount of excess fat you have and what percentage of it you've lost. So we may say with a sleeve gastrectomy, it'd be fantastic if you lose about 65 to 70% of your excess fat. With a bypass, perhaps 70 to 75. Everyone's very individual. It's we'll tailor that as well, because maybe you are in a wheelchair. It might be that you might lose significant weight, but it may not be as much as somebody who's now carrying on at their sessions at the gym, and they're able to also target more weight loss with exercise as well. So everyone's a little bit more unique and a little bit more individual, and that's really important to understand. Whereas if you're, say, looking at somebody and they go, oh, I've lost 5 stone in a week and I just eat toast, that's the kind of advice and the kind of sort of false information that we wouldn't want somebody to be following after surgery, to have ridiculous expectations and to be eating ridiculous things. So to be honest, you guys often become the experts. I know a lot of people that have ended up buddying either relatives or friends or family they know that have gone abroad for surgeries. So it's interesting what's out there, and you have to know when it's healthy for you, and that applies to almost anything, doesn't it? Some days you're happy to see what everyone's eating on Facebook, and other days you're just not. So it's knowing yourself and when to switch off as well. Okay, next slide. During your stay, you may be offered meals that are inappropriate for you. That are inappropriate for the recovery diet. So when you're in hospital, and the hospitals we use, so we've got Salford Royal that doesn't get to do as many surgeries as we like, because it's such a big centre, because there's such a limited bed capacity. And then the Oaklands Hospital, which is across the road, which is our private provider that can take patients that don't have any comorbidities that we would deem needed a big centre like Salford, and for ladies have a BMI of below 55 and for gentlemen below 50. So the Oaklands Hospital, they do private and NHS bariatric surgeries, and they're doing them most days. And then the other centre where you would have surgery with our team would be our main hospital, Salford Royal. So do you think during those hospital stays, whichever one you're in, you would be offered a meal that is inappropriate for the recovery diet? What have we got for true, do you think, Abby?
It used to be around 60 people out of 312.
Yeah, so let's go to the next slide. I want you to be, I say it's true, you may be offered a meal that is inappropriate. I hope that's less and less, but I can't guarantee it, because when you come to a multi-centre where we're looking for beds and we do not want to cancel your surgery, you may end up on a post-op surgical ward where the staff are very well versed in monitoring your observations and everything that needs to be done post-surgery. However, the nuances of some of the diets and medications, they're going to be waiting for our team to come and see you the next day, offer our expertise. And because we do get a higher turnover of staff, as I'm sure you're aware from the news as well, so not everybody's going to understand the rules of 20 and things like that. So we do lots of training, but it is possible that someone will come to you and say, oh, do you want the bowl of porridge the day after surgery? And of course, that's not something we want you to go, yes, please. So it's really important that you are now the expert in your aftercare, that we have excellent ward teams that will care for you, but on occasion there will be staff that may not know all your requirements. So you are fluids only on the day of surgery. So you would ideally sip water from a medicine pot, like a little tiny pot, and just pace yourself. Then you would start the liquid diet the next day. So that would be things like, yes, you can say yes to that half cup of tea. You'll probably be given a full cup of tea, but you will know that I'll just take it sips and the rest will probably go cold. You'll be offered a bowl of clear soup and sugar-free jelly. That's normally offered to you as your first meal at lunchtime the day after your surgery. And again, they may well offer you that in a normal size bowl and a pre-packaged sugar-free jelly and a teaspoon. And we don't expect you to try and have all of that. You just observe your rules of 20. If you feel full, then you absolutely stop. But it's just to make you aware that you ideally will be in hospital, have your operation and go home the following afternoon, evening. And when you're at home, you'll have everything prepared, things in your freezer, things in your fridge, and you're in control and you can get all that variety. In hospital, it's quite limited. You can ask for things like milk and you'll be given soups and clear jellies, and the odd, potentially, depending on how long you're there may be a yogurt with no bits in. But that's the very limit to the bariatric diet in a hospital setting. Next slide. All medications have to be taken as a liquid directly after surgery while you're in the liquid phase of the diet. So what do you think? Is that true or false?
We've got just over a third of participants raising their hand.
Yeah, and I think that's a sensible thought to have. So let's see, but it is false. Only essential medication. So we try and absolutely minimize what you're going to be taking as tablets, because the absolute priority after surgery is fluids. We want you getting to that 1.5 litres of fluids in a day. So only essential medications will be taken. So our bariatric pharmacist will look at the medications you're on and direct you on the ones that you'll be taking in the first 3 weeks after surgery. So very often tablets might be quite small. So for example, something like levothyroxine, that's an essential medication. You need to take it. Ramipril, bisoprolol, things like for your blood pressure, they're an essential medication. You'll need to take them. But you wouldn't need to necessarily take any kind of supplement or even certain painkillers you might not take. You certainly won't take any medication for your diabetes, because on a liquid diet, they just won't have the sugar content there to raise your blood sugars in the same way. So we tend to look at things and we try and make them as palatable as possible. So if they're a 5p piece or less, the actual tablet in question, then you'll probably be fine with that. Well, you will be fine with that. You can try and swallow that. If they're bigger, we'll look at the preparation and see if it's appropriate for it to be then given to you in a different form, ideally a liquid. If it can't be put into a liquid, we'll see if it can be crushed, and so on and so on. So we make sure that you go home with the things you need, plus a few extras. You'll have something called lansoprazole that dissolves on the tongue. We also have anti-sicknessings that dissolve on the tongue, and you'll have little tiny injections to ever slightly thin your blood to help prevent clots as well. So you'll be shown how to do those for going home as well. And that's from Risa Taylor, who's our specialist bariatric pharmacist. Your GP doesn't have to supply your supplements. So after bariatric surgery, for the best one in the world, there are certain things you're never going to get from diet alone. And it may not affect you straight away. It could be years and years down the road that perhaps you would have deficiencies. However, we follow the British Obesity Medical and Surgical Society guidelines, which give us a really good kind of balance of supplements that you need to take from 3 weeks after surgery to avoid becoming deficient in any of the micronutrients that you wouldn't absorb the same after the surgery you have. So we do write to your GP and we ask them if they will provide you with these. So what do you think? Do they have to provide you with your supplements? What are you getting through, Abby?
We've got 120 people, so a little bit more than a third.
Yeah, so let's go and see, is it true or false? Oh, hang on a second. Right, I may have put true and it could be false. So essentially, your GP no longer has to provide certain things. So your GP does not have to provide you with paracetamol, nutritional drinks, or supplements. However, we argue that because of the nature of your surgery, we would very much like them to give you the supplements. And for the most part, GPs don't seem to have an issue with this. The one that they might, and the one that is the least, that I have the most trouble getting GPs to decide that they will give you, is our multivitamin of choice, which is a multivitamin called Forcible. It's a once-a-day preparation that has everything we want in all the right values. These are quite big, so for some reason, for sometimes people can't tolerate them. They've got kind of like a jelly kind of gel, sort of hardened gel coating, and sometimes as they go down they can stick, so not everybody likes them and can tolerate them anyway. And then there are alternatives, so any A to Z complete multivitamin, but unlike what it says on the packaging where it will say to take once a day, because of your surgery you would take them twice a day. So there is cases where the GP will say, well, I'm not prescribing the multivitamin, but they seem to be happy to do your B12 or your ADCAL, which is calcium and vitamin D, and iron supplements. So it's very individual, and they are right. They don't have to actually give you them. But luckily for most of us, we managed to get them. So I like to make people aware of this, because if you were having to buy yourself an A to Z complete multivitamin, you couldn't get the cheapest generic one. It has to be an A to Z complete one, and that's going to incur you a cost per month to be safe and correct with this surgery afterwards. So you need to be aware of that. And that could be, depending where you find them, and it could be like £10 to £15 a month. So that's just something else to be aware of. Okay, next slide. My weight loss has plateaued. My surgery has stopped working. So what do we think? Is that statement true or false? My weight loss has plateaued. My surgery has stopped working.
I think someone's asked a question about this in the Q&A, and I've heard a few people mention it on the bariatric support group as well, on the Facebook group. So this is a good one to cover.
Okay, so what do you think? Does it mean that the surgery stopped working if your weight loss has plateaued? Is that true, or is it false?
Only 40 out of 300 have raised their hand.
Okay. So it is false. All of us lose weight in a pattern of a staircase rather than a slope. So when we think of a nice plotting a graph, or we've lost this much weight, then this much weight, and then you do a nice neat curve, with bariatric surgery, it's much more like stairs. So the time that you're sort of plateau, and we call like mini plateaus, so where there's no weight loss, it'll be, right, my body's holding on to fat right now, and then there'll be nothing, but because of your surgery, because of the diet you're on, because of everything else that's happening, your body has to start to metabolize that fat. I describe people as shapeshifters. So what will happen when you're on those plateaus is it'll be really weird, because you'll be going to your wardrobe, you'll be putting clothes on and thinking they don't fit, but when I step on the scales, I seem to be the same weight. What's happening here? Eventually the body, so as I say, it's a bit of shapeshifting, you're metabolizing fat, and you will then lose it. So you tend to go nothing, and then the stairs, as you go over your kind of 2-year weight loss journey, at first those stairs are kind of like this, and then the plateaus go longer and longer until you get to the 18-month to 2-year stage, when you will plateau out. From the evidence we have from the longest studies of people that have had these surgeries, there is a slight rebound weight gain. It's never a significant weight gain, but then people tend to then plateau off from there. So don't be fearful of little weight gains. There will be little fluctuates. So it's not uncommon for weight to be stable for a short period of time on the scales. Measure yourself with body measurements, so around your belly button, hip area. Monitor how your clothes are fitting. So there are other things that can just reassure you. Be aware of any changes in your diet, lifestyle, any grazing, because we do know that obviously it's just a tool. It's a little tiny tummy, and that you wean back onto full solid textures. But then if you're grazing and nibbling all the way through, then you can still get quite a few calories down through that surgery. So it is just a tool, and it's changed. It's keep sticking to those meal patterns and dedicated snacks that are the key to long-term weight loss. So revisit your eating habits, make sure you're taking time to eat, and stop eating when you're full, or the 20 minutes is up. And that comes from Fiona Chan, who is our specialist bariatric dietitian. You can gain weight after bariatric surgery. Oh, I feel like I gave you a spoiler there. Should we flick on to the next one? It's true. So let's have a look. I think what this one came from Chris Slater, who's our senior specialist bariatric dietitian. He says, after you achieve your lowest weight, a slight increase is expected. And as I say, that usually is around the 18-month to 2-year time after surgery. Unfortunately, obesity is a chronic condition and can return. Be sure to use your operation as a tool for lifetime change to minimize the risk of weight regain. If you notice weight regain, do get back in touch with the team. So yes, there's yearly that you'll have like a yearly appointment with our weight management team. At the minute, we do that for life. No one's come and told us to stop doing that yet, so that's great. But there is a 2-year dedicated pathway, which is seen the classic across the whole of England, where people tend to have this 2-year pathway. And during that time, sort of every 3 to 4 months, there will be a check-in with your dietitians. But you do have our numbers, so if ever you're sort of thinking, oh, well, we might just check it in, just getting a bit of reassurance, then do contact us, and we do our best to try and get back to you within the same working week.
And I will post the link for the YouTube channel for the previous session recordings, but I think Chris discussed that in a bit more detail in the last session, which is on our YouTube.
Brilliant. The best way to deal with cravings is to ignore them. Okay, what do people think? So this is an interesting one, because you do get a definite decrease in ghrelin, which is the hunger hormone production. But you still can get head hunger where you associate certain foods or certain things that you're really looking forward to having. So there can still be cravings, but it's funny because physiologically there shouldn't really be massive hunger, and that can buffer in a little bit at that time when you plateau off at 18 months, 2 years, which is why there's a natural bit of a regain where people notice, oh, I'm feeling a little bit more hungry for things now. But because you've just done 2 years of getting yourself into a set pattern, it's easier to manage. So the best way to deal with cravings is to ignore them. What do we think? True or false?
50 people with their hands up.
Yeah, brilliant. It's really difficult, especially if you've been putting on certain medications. So we hear that quite a lot, where people will say, oh, I'm absolutely starving ever since I started this medication. And it's so hard to ignore, and it's so hard to go for the things that you should go for when you have kind of cravings that you know won't necessarily weight gain. But after bariatric surgery, it's actually easier because the feeling of fullness comes very quickly. So you get that feeling of satisfaction. So it's just making sure you're mindful of the choices that you're making when you do get them. However, if you experience a food craving and it is helpful to act quickly, make sure that you have something to distract you. So phone a friend, do a hobby, go for a walk, have an apple, etc. Remember to be kind to yourself and use supportive self-talk. And I really like that phrase, because we can be quite hard, or somebody around us could be quite hard on us. So you do have to have that positivity when you're going through this journey, because it's a really big life choice that you've made. So it's like, you can do this. I got through this last time. This craving will go away soon. There are always going to be struggles. The surgery is brilliant, but it's not a magic wand, so there's always going to be struggles. Make sure that you reach out to friends, because cravings can be hard, and that comes from Dr. Sarah Lowe, who is our consultant counsellor and counselling psychologist. Brilliant. Okay, so next slide. Surgery is a tool for long-term health and vitality. You can achieve things you never thought you could. So do we think that statement is true or false?
Getting around just under half of participants with a hand up.
That's fine. I'm hoping that many participants cannot find the raise hand function, because I think that would be fair to say. Because yeah, absolutely, people are sat here considering surgery, or because they're waiting to have surgery, because that's exactly what they want to happen. They want to have lifestyle. They know they can make lifestyle changes, but they want a big change that will really help them with things that they want to achieve. And it's usually to do with longevity. It's usually to do with just being able to do more. I know I say that a lot in this group, but because I do all my follow-ups, it's a really big thing to be, just chatting to a gentleman this afternoon. He was just saying it sounds silly, but I can just put my socks on. And that's means the world to him, and that's really good, and that's exactly what these surgeries are for. So it's not just the big things that maybe us my healthcare professionals are like, brilliant, they're less likely to have heart disease, they're less likely to have this, that, and the other. I think it's the day-to-day that really, really matters. So lots of our patients see patient experience. So this oh, bear with me 1 second, sorry. Sorry about that. I'm still here. So this is Michelle. She did a talk for us, I think a year or so ago now. So if we go to the next slide, that was her before. And this is her after. So yeah, her talk was really great. And again, some of the patient experience ones are there available to talk again, but we try and do them fairly frequently because I think it's really important that you hear from people that have had the surgery, the highs, the lows, the everything. Okay, next slide. Okay, so here's Hannah. Her talk was really good. She really went into lots of highs and lows because I think that's really important to account for. Yes, that was her sort of before and after. And obviously some of these people are on journeys, so they may be halfway through their journey. And this chap has been many years down his journey. And one of the things he found that he really loves is both running and cycling. So Stuart's been a regular in our groups over the years, so you may have seen him in sessions before. But yeah, it's just an amazing. And then Lisa, so Lisa had her surgery and she had quite a sort of high-powered job. She was traveling around the country. She was having to do talks all the time, and one of the things she really struggled with was leaking edema from her legs. So she found that quite hard to manage in being in a public forum and doing talks and so on, and traveling a lot and having to not being able to just rest when she needed to and get her legs up when she needed to. And there were lots of reasons that she had her surgery, and she did really, really well with it. And she actually had some complications and had a revision of her surgery as well, but despite complications being there, which happened to less than 3% of patients, her journey may have been longer, but she's still got loads out of it. And now she's not in that high power job. She's now a foster carer, having a whole different kind of lifestyle. So yeah, really brilliant. A lovely lady. And again, I'm sure you'll see in our post-op support groups. And I think that's the last slide. Yeah, brilliant. I could keep going and going with all our post-op patients, because I think it's really important that you get the value from them and the whole picture, because it's so important that it's a major surgery that you're working with. And if there's any questions around anything that we've just talked about, we've got some time for that as well. Thank you.
Jodie. I'm just posting the link to previous sessions in the chat.
Yeah, no problem. I'm just having a look now. So if you get, I've got one. If you get a cold the week before your operation, but it's gone by the update, is that okay? No, so that's really important one. The anaesthetist with any surgery, and they normally say it's wise after a chest infection to wait 6 weeks until you have your surgery. And because of the way surgery lists are done, at the Oaklands in particular, it's a little bit more tricky at Salford, but because the way they tend to just book in a few weeks or ahead, so it won't mean that then you're going to have an absolutely massive wait to then have your surgery again. But yeah, people do need to be cancelled if they've had a recent infection, including chest infections. Can you share the best diet to do while on the wait list for surgeries? I'm struggling to lose weight. Okay, that's a really interesting question. It's quite varied. I think Abby and Lucy would probably be in a better position to answer that, but I would imagine this is exactly what you will be wanting to deal with in your tier 3 weight management, looking at those lifestyle changes. And I think for a lot of people, it's also having that acceptance that sometimes what happens is you can make quite good choices and you end up getting into a regular eating pattern, which is really important for life after bariatric surgery. And then you may just notice, well, I've lost a bit of weight, but now nothing seems to be happening. And that can be quite disheartening. And you still haven't had the surgery, so you're still getting all the cravings for the things you're trying to avoid. So we expect, a little bit of weight fluctuation. But at the same time, if usually sometimes it might just be cutting out fizzy pop, the amount of weight people lose just by cutting out fizzy pop, if that was their advice. So there's different things. So it's very, very individual. So definitely take that back to your dietitian that's attached to your team, because they should be looking at those things with you. But I guess where I was going is, once you do kind of lose a little bit of weight, you may notice that you plateau off a bit, and that's because you're not so much in a deficit. You're just eating healthily every day to maintain your calorie use. So don't get disheartened if weight loss isn't massive during your tier 3 weight journey. They'll explore that with you. They'll look at everything. So if you've just joined us thinking, well, I'm here to find out about bariatric surgery, I don't know if I actually want it, there are other options that could be that they would look at in more detail with you. These groups that we do at the moment, and we may be changing it a little bit in the new year, but they do tend to be very much surgery based. So we would say that most people come into our door is because they've done all the diets out there. Some of them are so ridiculous and they've lost loads of weight, but you can't possibly maintain that for life. So you get this yo-yo effect. And that's usually the case, that you kind of cross the threshold where fat is just so difficult to get down. It's just trying to get down as much as you can where you can maintain it and it's realistic, rather than any kind of faddy diet that takes a lot of weight off and then is hard to keep off. Let's see. Is that right, Abby? Is that okay what I've said?
Yeah, we would just recommend continuing what you've been doing on your weight management program, the sort of goals you've been setting, the changes you've been making with us, and also using it as a bit of a preparation period for bariatric surgery, thinking about what sort of changes you might be thinking about afterwards, like lower sugar, lower fat foods, no fizzy drinks, like Jodie said, eating slower, smaller mouthfuls.
Yeah, so there's a few, I'll just explain the pathway. There's a few things here about the pathway. I can't answer anything about weight loss injections. As always, it's really controversial. One, there isn't a great supply. Another injection's coming out called Wegovy, which already has the same supply issues, which is really heartbreaking for us all, because we know that a lot of these injections can be a really useful tool to actually lose decent weight while you're waiting for surgeries. And the NHS have said, put really strict guidance on it, and then some weight management services aren't allowed to offer it, some are. So it's so few and far between. I really would not pin your hopes right at this time in our history of kind of weight loss management tools on an injection as a way of losing weight. It certainly wouldn't be offered to you on a bariatric program, because you may be offered a weight loss injection to help lose weight, so that you can come down to a BMI that makes your surgery more safely. So people traditionally who were maybe at a BMI of 60 plus would have been given a gastric balloon. If it's appropriate, we might give those people an injection instead, and then give them the bariatric surgery. So we've brought you down to a safer weight. So that tends to be in our very, very high BMI category. So people might get that once they've come to Metis at Salford, but it's not routinely given out, unfortunately. And I can't wait until it is, but I don't think we're there yet, I'm afraid. So the way that things that work at the moment for the NHS, as I'm sure many of you may be aware or not aware, obesity is definitely the pandemic in terms of treatment that has been ignored for years and years and years. The pathway is there for people to get to bariatric surgery. The fact that you're in a weight management service means that you're on that pathway already. Once you get to the point where you're being referred to a bariatric centre, and those kind of guidelines, the things that you're asked to do in the weight management team, joining the psychology groups, meeting things like a 5% weight loss target, those kind of things, then allow you to have funding for a bariatric surgery. The waiting times to get into weight management services can be long. The waiting time to come and meet us at Salford is long. It's 66 weeks at the moment from referral. And that's just simply because of demand and the supply not being there. When you do come and meet our team, you then might need to have a psychology assessment. And that psychology assessment, again, may have a wait time on it. I think at the minute ours at Salford is around 5 months. You might need to have a sleep study. That's usually done within 3 months. And then when all those things are done, there may be other things. Maybe you've recently had a heart attack. We want to understand from your cardiologist your fitness for surgery and anything else that we need to be aware of. So there's all those things from meeting the team. And yes, when you meet our surgeon, they'll say to you, right, I agree, let's do the bypass. We'll list you for that. That doesn't actually mean you're on the waiting list for your bypass. It means that once all the other things are being done, then they would progress you forward for your bypass. And if you meet the criteria for the Oaklands Hospital, then it would be over there. So when all those things are done, the secretary then passes it on to the service management team, and we look for either a theatre date for you here at Salford, or we look for sending you over to the Oaklands. So I think there was somebody in there who was saying, oh, I phoned the Oaklands, they said they haven't had me yet. That's not something that the Oaklands would, if you just phone them randomly, they wouldn't be able to help you with necessarily, because all those things need to be done. And then when you meet our surgeon and the team, the surgeon's letter in the top right hand corner, their secretary is on there. So once you know, oh, well, I have had a sleep study, well, no, I didn't need it because I've already got a CPAP. Did I require psychology? Okay, that's about a 4 or 5 month wait. So when you get to 4 or 5 months, or after you've had your psychology assessment, if you give it a few weeks, and it's reasonable to then ring the secretary and see where things are up to. But normally you would then go over to the Oaklands, and the Oaklands, because we can get so many more surgeries done there, they do have a shorter waiting time. But obviously the more people we can get done at the Oaklands, the less people we have to do at Salford. So there's ways around it. But I would say that once you've had those things done, then you can proceed for your surgery, whether it be at Oaklands, where hopefully you would have your surgery within sort of 3 to 6 months of being sent over there, or if it's at Salford, it could be up to a year, unfortunately. So these are long pathways. They're not, it's not that I go to weight management and then I'm having my surgery. Unfortunately, it's not like that. And I think I still find it quite heartbreaking, because I've seen when we've been able to do it more quickly, and I hope we get back there. But at the same time, I think we have to think of it differently now. It's a longer journey. Attending these sessions, checking in, knowing that you've got the funding there to have surgery with us is really important. But yeah, it is long waits. And I often quote, from coming to meet a team to having surgery could be up to 3 years. And I think that's very realistic. Right, I'm just seeing if I can have a look.
I've seen a couple of questions.
Oh yeah. So you're right. So NICE guidelines, Department of Health guidance to prescribing, everything that's there. I completely agree with you. But if you haven't got a commissioning body that are funding it, we can't give it. So the NICE guidance is there, and we're going, look, commissioners, the NICE guidance have said that we should be using these things. The NICE guidance has said that you shouldn't put a 5% weight loss cap on people being able to access surgeries. We want them to change it, but the commission services are completely different, and that's down to the government and the money that they give to the hospitals. So it's really frustrating political process. So yeah, you're right. We have bodies that we employ to say, yeah, this is fine. I think Wegovy is available, absolutely, but to try and, you can't get it from a GP. It has to be given by a tier 3 weight management service. So there's lots of things where we're hammering at commissioners' doors saying, please give us pathways that are in line with guidance, but that doesn't mean they necessarily are. Okay.
Do you think people have asked about returning to exercise after surgery, like swimming or contact sport? Is there any kind of guidance on that?
Yeah, so keyhole surgery, the surgeon will happily see and say, oh, you can do whatever you like, whenever you like with keyhole surgery, it's great. And I agree with them to a point. I would say avoid things. It's an abdominal surgery. I would say avoid contact sports, weightlifting, anything that's really going to be like rowing machines that really go on your core. Avoid those. We'll say to 3 to 6 months and ease in gently. If you're getting pain, stop. But swimming's a really nice one because it's gentle resistance. It's quite a good way to get exercise. Anything cardiovascular. If you tell your gym you've had abdominal surgery, they'll be able to guide you to which machines you can work on. But yeah, no, 2 to 3 weeks we expect you to be back to your usual activities, and then you can build up from there. You can get surgery if you've had C-sections. That shouldn't stop you having surgery. I'm trying to see what questions else we've had. How long would you need off work? 2 to 3 weeks, and then you can return to driving and going back to work. Obviously, if you have a more manual job, then you might need to do a phased return, and that's not a bad idea if you're working longer shifts or it's very physical.
Jodie, the sleep study, what is the sleep study for? And does bariatric surgery help with sleep
Yeah,
apnea?
absolutely. Yeah. So we do a sleep study because we're looking for a condition called obstructive sleep apnea, which is basically where when you're in a sleep at night, your body's waking you up because it doesn't feel that the oxygen and carbon dioxide exchange is happening efficiently enough. So it wants you to take a deeper breath. So you're in your REM sleep, which is that world between awake and deep sleep, and as soon as you go into your deep sleep, which tends to be when obstructive sleep apnea is more of a problem for people, especially people that are obese, it will wake you up ever so slightly. So you won't necessarily wake you up fully, but it will wake you up enough to take a deeper breath, or to be repositioned, or to stop snoring, or whatever it might be. And then you wake up in the morning feeling absolutely tired because you've not had a deep sleep. So finding out if you have this condition, one, it can be really useful. So if you are a terrible snorer, or you do wake up with fatigue in the morning, then maybe you need to get to your GP now and say, oh, I wonder if I've got this sleep apnea. Because there is a treatment for it. It's called CPAP, which stands for continuous positive airway pressure, and it's a machine that you have to wear. It sounds like, oh, I don't want to do that, I'll never get to sleep with a machine on my face, and some people can't, and lots of people can, and when they do, they notice almost instantly a difference in their quality of life because they're getting decent sleep. The reason we ask everybody to, or almost everybody, to go for this is because our anaesthetists will quite like to know if you have that condition. It could bear on where we would look after you. If you have obstructive sleep apnea and you're on a CPAP machine, then you can go to the Oaklands Hospital as well. So it's these sort of things that we just need to be aware of to keep you as safe as possible. And again, we can actually boast that bariatric surgery cures obstructive sleep apnea, and that can happen very quickly after surgery as well. So even if you are found to have this condition and you need the CPAP machine, having the bariatric surgery should then mean that you don't have obstructive sleep apnea or need the sleep machine anymore.
Thank you.
If you already have sleep apnea, that's fine. Just let the team know you don't need to have a sleep study. If you're using a CPAP machine, brilliant. That's something you need to bring with you on the day of your surgery. So if you've been suggested to have sleep apnea and you can't tolerate it, that's fine. It just means that the team are aware that you've got it after surgery, that you haven't got a CPAP machine. So if there were issues with your gas exchange in the night, it's just going to be looking at monitoring that a little bit more slowly, and it would mean that you'd have your surgery at Salford. Some people have said, what if I fall pregnant on the waiting list? So once you've met us, or even in your time of referral, I'm really try and do everything to make sure that the worst doesn't happen, and they go, oh, you're pregnant, we'll just discharge you, and then you have to start the process again, because I have heard of that happening in other areas. I say no, stick a pin in it. Now you and baby are priority. You've done your weight management, stay active in the support groups, feed back into them, and then we can pop the pin out once you're postpartum and get you back in seeing our teams and so on. So no, these things happen, that's life, and you've got to deal with it, and then on we go again with the surgery and revisit where you're up to and what your needs are. So it could be that but you might have some more dietitian support beforehand, or you might not need it, but no, you and the baby would be the priority, and then get back onto the program once you've had the baby and you're happy to proceed.
There are a few questions around health conditions that can stop you from having surgery. Is that something that you can answer, or is that best answered once someone reaches the surgery provider?
Yeah. So there might be conditions. There's very few generic conditions. There are conditions that people can have that will mean that they the way, like for example, like Cushing's disease and things like that people would look at, doesn't necessarily mean you wouldn't have surgery. And obviously your Tier 3 weight management service will look at things like this in your history and so on. There are sometimes, if you're just not fit for anaesthetic, if the risk is too great, and really when you look at people who are obese, they're already aware of the risk of their obesity. So if there's an increased risk with anaesthetic, and we're happy that that increased risk is something you're aware of, we can still proceed. So there are health conditions we're going to want to know more about. We're going to, if you're on dialysis, we're going to make sure you get dialysis at certain days, and the way we look after you afterwards. If you've had a stroke or heart disease and you're on drugs that thin your blood, we need to advise you on when you come off them and when you go back on them. So sometimes those health conditions that make you feel fearful of having bariatric surgery are the ones that are going to greatly improve with your weight loss. So we have to weigh things up, the risk versus the benefit, and that's something that we would do. You would be sent for an additional anaesthetic review, a review of your heart and lung function and so on, with our preoperative team. So don't be put off if you've got conditions that you're concerned about. And when we have our bariatric physicians and our bariatric surgeons, it's quite interesting the questions they get asked there about conditions and so on. So do stick with these sessions because they can be really useful. So the first meeting when you come to Salford, we would expect you to already have taken on kind of all the lifestyle advice, have a good knowledge and research around the bariatric surgeries. You'll be sent a video link of the booklets as well as the booklets. So depending on what kind of learner, is a refresher and very much more specific to Salford, because there are other providers in the north that sometimes they may say, well, would you rather go here for your surgery or there for your surgery? That now and then does happen because of how long waiting times are. So the information that you get sent from Salford is very specific to us. However, it's fairly similar to a lot of the services around, because we are regulated bodies and we do often follow similar guidance. So you'll have a video format if you're more of a visual learner, but you'll have a booklet format as well, which is quite useful for the tables and things for the liver reduction diet you do before surgery. So you'll have all that information sent on to you. Then you'll be invited to a Q&A. It's a little bit like this, but so much smaller. So there's not very many people there, just a few of you, and we just pick up on what happened in the meeting when you came. So when you came, you would have had your blood done, you will have had your observations taken, your weight taken, you'll have come and met the surgeon for definite, and then possibly a medic as well, depending on your medical history. And then a few weeks later or before, depending on which way around you prefer to do it, you'll attend a Q&A with me and Chris, the dietitian. And then at the end of that session with the surgeon and having your bloods and everything done, there's a multidisciplinary team meeting that just goes through things like psychology scores. Obviously, when you're referred on to us, your referral comes over to us and we look at what your journey's been in the Tier 3 weight management service. And from there, we would say whether a sleep study is needed, whether psychology is needed. Psychology is needed a lot, so majority of people have it because it's a good assessment. It's about an hour and a half, and it's looking at where you are, where you were, where you want to be, and that kind of psychological toolkit. So they will expect at that psychology assessment that you have a good understanding of surgery and living with surgery afterwards. So part of your 12 or 6 month pathway or whatever it is that you are with your weight management service, all this kind of information and all this learning so that you can do the surgery well is really important. So when you come to meet us, it's not like a big program, it's the surgery, and then you have follow-up care with myself and the dietitian, and hopefully never see a surgeon again because they'll only see if there's a problem. And then there's a post-op support group that you can tap into as well. So really, in terms of expectations, you're coming to meet the team because you're coming to meet the surgeon and get an understanding of the hospital and which surgery is going to suit you.
I heard a few people asking about the next sessions and links for the next sessions. So in January, there won't be a bariatric information webinar. The next one will be in February. And you should already be signed up to it. We will be sending like bulk emails out in the new year to make sure you all are signed up for the next lot of sessions. So don't worry about that. So the next one will be on the 7th of February. I just noticed a few people are starting to log off now. So just want to make sure that question was answered. And we've also got a few questions that we get asked quite regularly and that might well be covered in really good detail in previous sessions. So previous sessions that we've had have been with like the pharmacist in the tier 4 team at Salford Royal, or the dietitian, or the surgeons, or patient experiences. So have a look at the ABL Health YouTube channel, and I have put the link in the chat to get a bit more detail on different topics.
Someone's just saying it to explain the tiers. So yeah, apologies for that, because sometimes we do use jargon and don't mean to. It just gets a bit confusing because there's weight management and then there's the weight management, metabolic and surgical team. So tier 3 is weight management, and weight management in terms of tiers, traditionally when the government set it all up, there was sort of tier 1 is classed as you're doing a diet. Tier 3 is that, oh, I've joined Weight Watchers or Slimming World or something, I'm doing it in a more organized way, or I'm part of this gym program, blah blah blah. Tier 3 is where it's a structured service and it's the gateway only for maybe medical weight management or bariatric surgeries. So all of you are in a tier 3 weight management service right now. That's why you're here. You're exploring your routes and your journeys for weight loss. And one of the ways that people lose weight who join these services is with a bariatric surgery. So once you've completed the service here that you're in and you want to progress to bariatric surgery, this is the only team that can refer you on to bariatric surgery. Your GP couldn't do it. We do have a fast track service for people that have a cancer that needs weight loss that they can't get to. So we can do some fast track work for curative procedures or people that aren't getting access onto a transplant list because their BMI is too high. So we do some surgeries, and even then I'm afraid it's not very quick, but it is quicker. But no, for almost every, the vast majority, you're in a weight management service, which is classed as tier 3. And then once you've met the team at Salford, that is a tier 4 service, which means you're having a bariatric surgery and you're having a 2-year pathway of follow-up care. So this is how kind of the tiers work with these surgeries. Yeah, antidepressants are classed as a essential medication. You would absolutely be able to take those after bariatric surgery. And an age does not go against a person where surgery is concerned. You can meet somebody quite young, like 60, and they could actually be very, very, very unfit. And you can meet someone who is 75 who could be fitter in terms of for a surgery. So we don't. There isn't really sort of an ageist part of this. Some people will lose amazing weight in tier 3 weight management, and when they come to us, they may then be below a BMI of 35. You can still proceed for surgery because you came to us and you've gone a weight management journey, done really, really well, and we're going to question you, is this really what you want to do? Do you want to carry on doing really well? Do you want to just, like, you know, we can carry you on the waiting list because we know that there's still going to be a wait to surgery. When you get to the time when you're being offered a surgery, you don't have to go and go, yes please. You might go, actually no, I've carried on doing really well and I don't want it anymore. So don't worry if you're losing weight and you think, oh, should I be having this surgery or not? But you're worried you're going to put it back on again, still stay on the pathway because it is long, so it gives you time for that. Also, people are worried about, well, what if it's the other way around and I put weight on? So I've met my 5% weight loss target and you made me wait 66 weeks to meet you and I've put weight on when I meet you. Are you going to turn me away? No, we won't. Sometimes if it's very excessive, we're going to question things and we might give you further support. But no, we expect people's weight to have a bit of a yo-yo. And hopefully once people have met us and they've got a better idea of the direction they're going in again, it can help refocus. So that's really important. So no, you're not too old at 68 for bariatric surgery. I saw that one. Okay. Okay, I'll make this one the last question. So someone's just saying, do you need to stop smoking for bariatric surgery? Yes, you absolutely do. Unlike other surgeries where they'll tell you to stop for 6 weeks. Oh, there are other surgeries, I'm sure, but majority will say you must stop smoking for your anaesthetic. With bariatric surgery, you must stop smoking lifelong because of the increased risks of ulcers forming on the surgical joints inside, and the risk of malnutrition, the risk of not healing. So it's really important to stop smoking lifelong. So some people say, well, can I vape? I know we're getting more and more, and we're worrying more and more about our youngsters now with the data that's coming out about vaping. However, it can be a good caveat to come off cigarettes. So if you are weaning off a cigarette by using a vape, then you need to wean down to a 0% vape, and then you try and minimize your usage of the 0% vape. That would be acceptable. And people do, Oakland's, I think they specify that you need to stop vaping a month before surgery. Again, it has to be a 0% vape because we don't want you to have any nicotine after surgery either. I guess part of this journey, if you are a smoker now, is also that you're going to be healthier for not smoking too. Brilliant.
Thank you, Jodie. We've managed to get through 70 questions there.
Well, really?
Yeah,
Okay.
thank you, Lucy. You can see you typing away throughout the session as well.
Thanks so much, Lucy. I really appreciate you coming and doing that as well. So yeah, and thanks so much, Abby. Thanks everyone for listening.
Yeah, and thank you, Jodie, for the information. A lot of people in the Q&A have been thanking you for recapping.
Oh, thank you very much.
Sessions.
It's still a pleasure, even though I always feel sad that waiting times are longer and we're still not getting taken as seriously as we should to get these surgeries done. But we're all here because we care, and we definitely see this as a cause that we're going to keep fighting for. So I know there's lots of frustrations. So thank you for bearing with us, and thank you for attending these. And I hope you'll have a really lovely Christmas. See you in the new year.
Everyone.
Thank you. See you all in the new year.
Bye.
Bye.
Bye.